Good afternoon, everyone. I can see people are joining. Thank you for joining us today. We just have a few minutes until everyone's here, so we'll try and start promptly around 2 o'clock, just as soon as we've seen that people have come in. Thank you for joining us. Get started. Thank you everyone for joining us today. I hope you know where you are. You are in a webinar on the next evolution of AI and fully automated clinical documentation, and we'd really like to welcome you today. We are being recorded, just to for everyone to know, and just welcome from a chilly but quite beautiful day. I'm in London today. My name's Leah Ali. And we'll be hearing from an amazing panel of speakers about the journey of the University of Michigan Health West, an early adopter of DAX Copilot, a new solution which combines conversational and ambient AI with the latest generative AI. We'd be really grateful if you'd put questions in the Q&A sections, as our panel are really keen to hear from you, and we'll have a good amount of time towards the end of the webinar for us to answer those questions and think about those together as a panel. So I'd like to move quite quickly to our wonderful panel and ask them all to give a couple of lines introduction to themselves. Just to kick off, I'll introduce myself. So I'm your chair. My name's Dr. Leah Ali. I'm a practicing physician. I'm a consultant neuropsychiatrist at the South London and Maudsley Hospital, so here in South London. And I also work at a national level in digital policy and practice at NHS England. And I chair here today in my capacity as a CCIO advisory panel member of the Digital Health Network. So Lance, can I go to you first? I'd be grateful if you could introduce yourself.
Of course. Good morning. Honored to be here. My name is Lance Owens. I'm a family practitioner and currently serving as the Chief Medical Information Officer at the University of Michigan Health West, which is an affiliate hospital of the University of Michigan in West Michigan. I believe CMIO would be equivalent to what you all would call the CCIO, just to give some reference. Right. So looking forward to the conversation this morning.
Great. Thank you, Lance. And Peter-Marc.
Hi, my name is Peter-Marc Fortune. I'm a paediatric intensivist based at Royal Manchester Children's Hospital, where I'm also the CCIO with responsibilities across all children's services covered by the hospital, but also across the whole of Manchester Foundation Trust Group. And we've recently, pertinent to this conversation, we've recently gone live with both Nuance and Epic across our campus in the last year.
Lovely. Thank you, Peter-Marc. And Simon.
Hello, everyone. My name is Simon Wallace. I'm the CCIO for Nuance. My clinical background is hospital medicine, general practice. I've been with Nuance for the last 7 years.
Lovely, thank you. So I think we're going to kick off today with a great presentation from Lance. So Lance, over to you. Are you all right with your slide sharing?
We're getting there. How are we doing? Can you see it?
Yep.
Yeah, good.
Let me start here. Okay. Yeah. So this morning, I've been asked to talk a little bit about, some of the solutions that we've used for really the bottom line is physician burnout. And we have a philosophy here at our institution when we bring on a technology that the technology needs to be patient-centric and provider-focused. And we really try to use our digital arms to wrap around our patients and promote the intimacy of that relationship between our patients and the providers. And when I say provider, I don't necessarily mean the frontline, physicians and associates. I'm really talking about even up to the institution. I have no disclosures. Oftentimes when I talk about DAX, I'm oftentimes, geez, are you paid by Nuance? And the answer is no, I'm not. A little bit about our institution first. Like I said, we are an affiliate of the University of Michigan. In some sense of the word, our scale would be fairly small, but I think we're mighty. We have about 250,000 patients annually that we serve, 17 outpatient centers, 30 specialty lines. We just started a de novo open heart program. So from the ground up, we opened an open heart program, which has been very successful. Our main hospital is 208 beds. We have about 3,000 employees. And I think of note is that we have been on Epic since 2006. We've had a full Dragon adoption since 2006. And I think I'm pretty proud of the number of our users that actually use Dragon because it is a very good efficiency tool. We are the first organization to have an enterprise license for DAX. We've been on the DAX journey now for really with pre-planning for probably close to 4 years. But I think the thing to talk about first is really about, physician burnout. What are we what are we trying to address here? Why are these tools so important? And it really is a prevalent issue within the healthcare industry. Causes, would be workload and stress, the demand of the healthcare environment and the pressure to see patients and, the long hours in which we need to put in to do those things. A lack of autonomy is really big. A lot of times standardization in the EMRs or in workflows or simply who is allowed to be on your schedule, for example, really has effect on autonomy. And then there's just simply emotional exhaustion, from the constant care of or the cycle of caring for others and really leaving not enough time to take care of yourself. I'm a big fan of the work-life balance. And it is a really big problem. Currently in the United States, about 50% of physicians say that they are reporting symptoms of burnout. During the pandemic, depending upon what report you looked at, that could have gone as high as 76%. With in some reports, close to even 2/3 of providers even thinking about leaving the profession. We recognized here in the United States, I assume this is global, that there are certain specialties that are affected. Emergency medicine, critical care, even primary care is fairly high up there. And it does seem that females tend to be more susceptible. And I think we all know that female are the superheroes of our society. And they have a lot of pressures on them. The effects of that burnout, there certainly is an issue of decrease in quality care just from the emotional investment of what you're doing, which increases to medical errors and really poor doctor-patient communication. And I mean that not just between doctor and the patient, but I mean the doctor and the EMR. Sometimes when someone comes in and they just have a multitude of complaints, it really is cumbersome. The burden of putting that documentation in the note really is a problem. And so for us, what we feel is that part of the issue is the fact that, we put a computer in the exam room and it's a big distraction, and we've created a triangle of attention. And with what we need to do to make these computers to be most effective is put in data. And what we've done is we've created a profession of the most expensive and highly paid data processors in the world. And we need to get away from that. We need to get away from the time on the computer and more time at looking and treating our patients. So as part of a strategy of how we're going to combat this at our institution, like I said, for a number of years, we've been looking at ambient artificial intelligence solution. I'll get to that in a second, but I thought it might be worth just very briefly getting on the same page of what artificial intelligence, means. And, there are many definitions. This is the one that I came up with, that artificial intelligence refers to the simulation of human intelligence in a machine that can perform tasks requiring human cognition. And the interesting thing is that it can do it very, very fast, millions and millions of calculations a second. It really enables computers to learn from experience and adapt to new input without any explicit programming. So I think we all know that computers can now learn, and the interesting thing is that they can learn from each other. Under the kind of cohort, if you will, of artificial intelligence, there are several features. There's more than this. These are the ones that I think are commonly come up in our conversation, and particularly will help us in healthcare. And that is machine learning, and that is basically for the machine to learn from algorithms, which enable the computer to process large amounts of data and start looking at patterns. Natural language processing, where the computer can learn a language. They now say that ChatGPT can learn an entire language in 14 minutes, which is just mind-blowing to me. But it can start to understand, interpret, and even respond to human, both in written and in voice. It also allows it to do translation, which I think is going to be a wonderful thing in healthcare. Robotics, I threw this in here because of the robotic assisted surgeries that we do. There are some that would say that the combination of a robot and artificial intelligence will be able to actually do some surgeries in the future. Not so sure that's the right thing to do, but that's an ethical question about this artificial intelligence, which really would take up more time than I've got. And then there's computer vision, which I think is very interesting in our industry because this artificial intelligence will be able to interpret what it is seeing. It already is doing that But what a wonderful thing to be able to have a camera above an operating suite and be able to document and see what is going on during the procedure, and maybe even alert a provider if a sponge was left in, a tool was, or something was awry, there was a bleed detected that wasn't seen. So just some very interesting capabilities and opportunities with artificial intelligence. Some major uses in the medical community right now. I'm not going to spend a lot of time on these, but medical imaging, these computers are able to see images not even down to the pixel, but down to the partial pixel and maybe even wavelength. Certainly being able to analyze tons and tons of data is going to help with the drug discovery and development. And of course, the electronic medical records. We're working on several initiatives with artificial intelligence within the health record to help our providers be able to see their patients more efficiently with better quality. And then what I'm excited about, we're starting to toy with this as well, is using AI to come up with personalized treatment plans and recommendations for our patients. Being able to take the patients, their actual data, and compare it to the literature to see what treatment might be best for them. And I think if you break all this down, we're looking at 4 categories of use. Automation, things that can be done for us. Something as simple as scheduling patients so we don't have to have people, wait on queue for scheduling appointments, to summarization. And that could be anything from, ask the computer what happened to the patient since their last visit. Ask the computer what happened to the patient and during their hospitalization, to be able to give a nice summary for that. Handoffs, those types of things. It's able to create, and right now what we're talking today is we're talking about the generation or creation of the office note, which believe me, taking away that burden is a beautiful thing. And then translation. I would love to be able to, and we probably will very quickly be able to do this, take my recommendations or a handout that I have that's in English and be able to say, give this to this patient in their native language. And it really could be any number of, hundreds of languages that could be translated into for the patient. So really, the term I use is that it's going to revolutionize healthcare, and I think it's doing that, kind of bits and bits at a time. It really is going to empower our medical professionals. It's going to improve our diagnostics and really enhance the patient care and, quite honestly, their experience. So to show the power of artificial intelligence, I have a confession to make. Every slide up to this point, which did not have the University of Michigan Health logo on it, was actually created by artificial intelligence. I just asked the computer to give me a few slides on physician burnout and a few slides on artificial intelligence. And these slides, unedited, is what the artificial intelligence created for me. That's the content, the background, the graphics. The pictures aren't even real. They're generated by AI. So it's an incredible tool that can be very assistive and in many ways. But I understand that there's some ethical issues to that, but I just wanted to show the power of artificial intelligence. So let's talk about DAX Copilot. And I want to start with this story. This is a patient I saw Monday. Yeah, he was coming to me for his regularly diabetes, high blood pressure, high cholesterol checkup. He's doing fine. He's a well-controlled diabetic. He would be considered, like a poster child patient for my diabetes as far as how he takes care of himself. And we had a nice conversation. He was there with his wife. And this was the output of the diabetic portion of the visit. This is unedited. As you read it, you can see there are some things that probably should be cleared up. There are some issues within this text that you might want to clarify. But this is a pretty good summary of what happened at that visit. And then as I'm leaving, his oh, by the way, was he asked me to write him a letter because his house was raided a few weeks ago because his internet, his IP address was stolen and found on the dark web in association with child pornography. This was not a turn I expected the visit to take, but the ambient listening and the natural language processing, the artificial intelligence was able to take that very unique conversation and put it into a fairly good summary of what we talked about. Again, if you read it, I don't think this topic is in the wheelhouse of nuances, medical, ambient voice listening. So there are some mistakes in there that will need to be fixed. But this was the output of that patient encounter using DAX Copilot. I did not write any of this. So what is DAX Copilot? What am I talking about when I use this for my documentation? We have decided to use the phone-based app. So there's an app on your phone which connects through your EHR through Dragon or Dragon Medical One DMO. It allows you to use these services right within the EHR. So you basically record the conversation. I always ask consent for the patient. Do you mind if I use DAX? It's interesting. I've been using this for so long. If I happen to leave my phone in my pocket, the patient will actually ask me, "Hey, are you going to use DAX? Are you going to get it out of your pocket?" So patients, I think, have noticed the benefit of it. You record the visit, and when you are done, you hit the microphone, and the artificial intelligence automatically spits out a report similar to the one I just showed you. It's hard to see, but in the summaries are listed in that third pane there. And then the fourth pane is actually what is the summary itself. So you can go into the app either on the phone or on the desktop, edit anything that needs to be edited, and then transfer that into your EHR. It sounds like a bit of a step, but I was working with someone yesterday who uses a different iteration of DAX, a completely automated iteration of DAX, not automated, but automated in the fact that the provider does not need to put that in the system. It's just an earlier version. There's a human in the loop. But he's like, why would I ever do anything else? That's just so easy for me. After 2 or 3 visits using DAX Copilot, he was completely convinced that this was the way to go. This feature will be the way that we bring artificial intelligence into the exam room, and not just in note creation. Note creation is simply scratching the surface of what we're going to be able to do. When you talk about being able to automate things, do some summarizations, natural language understanding, editing, being able to do some implicit ordering, pull up quality data, images, labs, just by simply speaking about them to the patient, that will certainly be advantageous to us who are seeing patients. This technology, of course, is going to permeate throughout the entire institution. They're working on some strategies for nursing and for other allied healthcare professionals. So this is truly the iceberg phenomenon where we're just seeing the tip. So I'd like to talk about, how we did this. We started out with a pilot. Like I said, we've been live with Dragon since 2006, and with a different version of DAX since April of 2021. That was a version we knew was going to be sunsetted eventually because, like I said, there's a human in the loop. It's very, very difficult to scale that. It's quite expensive, quite honestly. So we knew that this would eventually be sunsetted. And so that is being what DAX Copilot is. So we selected a small cohort of our providers who were asked to be part of a private preview of Copilot. This was back in March, I believe, we started this conversation. And we chose providers based on various key performance indicators, how much they use Dragon, how often they're at time and notes, what their artificial intelligence score is, which is something that was calculated for the patient for the provider through Nuance, and then really their general willingness to try something new. And we wanted to get providers of all phenotypes of how they use and interact with the system to see what the impact would be of DAX Copilot. We've been working with them since the private preview with Nuance and Microsoft to do some optimizations, and we very, very quickly saw the advantages of this type of technology. So here are just some basic statistics. These are national statistics here in the US. I point that out because I'm going to show you some statistics which are a little different for that, but are unique to our institution. But you can see an average of 5 minutes saved per encounter. This is not just time in the exam room. This is also time doing the documentation outside or prepping for the patient. So if you're seeing 20 patients a day, that's 100 minutes of savings. That adds up quickly. People saying that they can see another additional patient or two during the day. Patients love it. The providers love it. 77% said they'd be disappointed if you take it away. 64% said it reduced burnout. I'm not going to read these to you. You can see them. But if you look at, all of the facets that we would like to see improve, from efficiency to satisfaction to quality of the documentation to the patient experience, they all have improved. What I find very interesting is under the patient experience, the patient perceives an average of 4.8 minutes of reduction of time spent in the computer. This is the patient saying this. And what was interesting, if you go back and look at this data, sometimes those visits aren't even 5 minutes long. So the patient feels like the time saved is almost as long as the whole appointment itself. So it puts patients at a very different mood when you're seeing them. And really, the entire visit changes, and I'll get to that in a moment. So some of the stats that we've seen using DAX, you can see in the upper left there, just time and notes per appointment has dropped almost 2 minutes. Again, if you're seeing 25 patients a day, that's a very significant improvement. Our time and notes was pretty good to begin with, which is why I think we're an interesting case study for DAX, because it even improved us that are doing pretty well. Time and notes per day significantly dropped. And then we also measured time providers were spending outside of their schedule. So that could be before the patients start, after patients, weekends, and their time was going up in terms of spending time outside their schedule hours, and then came to back down to pre usage. I suspect this is going to go down even further as DAX continues to be rolled out. DAX Copilot. Our patients love it. The patient experience certainly has improved. We asked this very interesting question, rate your visit compared from previous visits from the same provider. So, your last visit, a visit that you used with this provider where they did not use DAX, how did this visit compare in terms of felt like the conversation was more personable, seemed like it was more focused, and spent less time on the computer? Out of 5, we're right up there at 4.6, 4.7, as you can see. But what's interesting is that we asked this very same question to the same patients of how did you feel this visit was compared to providers outside of our health system or previous healthcare encounters? And the scores bumped a little bit. It doesn't look like much, but it is statistically significant when you run it through the statistical analysis. This is something that I think a lot of people are interested in many different ways. For me as a provider, I look at this, and really what this graph is telling us is that those that use DAX greater than 60% of their visits, and we have a goal of 60%, and we have found that using it for 60% of the time really is where you start getting some really significant benefits all over the place. In your office, how you use your in-basket, how your referrals go. There's just tons of kind of soft ROIs for this. But those that use DAX 60% of the time are seeing 21 more patients per month. Now, it says 9 there or 12 there on the box. That's because they compared it to the 9. If you use DAX less than 60% of the time, you're still seeing 9 more patients per month. But I'd like to focus on the fact that if you use it 21 or more than 60% of the time, you're going to see 21 more patients per month. And this is interesting to me because at this time period that we collected this data, another effort was actually decreasing the amount of hours that providers were required to see patients, to help with the burnout. At this time period, they went down from 32 to 36 hours and still increased the number of patients seen per month by 21. So a very interesting statistic to us. That tells me that there's increased access for our patients. The throughput is better. It's more efficient. But as a part administrator and someone who's fiduciarily responsible for the hospital, that also is a significant input in revenue. And it tells me that this system definitely pays for itself. And one of the things I think I am most impressed with and happy about with this is that we did a study on burnout to see what the effect was on burnout. This data was taken at a different time than that other data. So that'll be evident here in a second. So this is looking at a burnout survey tool that we used. It looks at burnout in 2 different ways. One of them is disengagement, if the provider is disengaged with the system, and then their level of exhaustion. And it showed a 3-point improvement in the overall level of burnout, which equated to 2 points for disengagement and 1 point for exhaustion. And that's really significant to me. It was statistically significant, again, when you run it through the stats analysis. But exhaustion is one thing. I can work with a tired doctor, and we're probably not going to have much impact on that unless we make some major changes in the healthcare environment. Because even though if doing documentation is easier, I still have the same number of emails, patient advice messages, refills, patient calls. I still have other responsibilities, which will certainly take up my free time during the day. So I don't expect exhaustion to improve that much. But the disengagement, as a physician leader, when a provider is disengaged, when they've checked out, that's very difficult to recover from. And so the fact that we have a tool that decreases that, not only did it decrease that, it decreased that at a time period where they were seeing more patients per month. To me, that is a very significant, meaningful thing. So the system is being able to see more patients, the patients have more access, the provider is happier about it, and they're making more money, because in our system, if you see more patients, you actually have a higher salary. That equivalent, that 3-point drop in burnout level in the United States is actually equivalent to a 4 points of drop in burnout when someone goes to a part-time or half-time status. And someone will say, well, you just said that you let your providers go down to 4 less hours per week. These stats, like I said, the data was taken at different time periods. So I think that we have a very nice combination of what this tool is able to provide. And really, for me, as a practicing physician, the bottom line is, it is just so nice to be able to walk into an exam room, sit back in a nice, relaxed pose, look my patient eye to eye, have a deep, meaningful conversation, whether it be about their diabetes or the chance that they might go to prison for the rest of their life. Get all that information, deduce all that information, put that into a differential diagnosis, think about an evaluation plan, an education plan. I have all that discussion with the patient, and the whole time I don't have to look at the computer unless I'm showing labs or ordering something, and have that nice, relaxed conversation, be fully engaged, and know that in the background, all of that information is getting documented, it's getting captured, and I don't have to worry about it. The relief of the burden and the administrative task of doing that in and of itself is just an amazing thing. I don't think anyone can understand it until they've been a provider on the kind of on the race, seeing patients, and then being given this tool. I tell people that, just imagine the worst part of your job, the absolute worst part of your job, and I give you a tool that's going to take away 90% of that. That's what this technology does. That's what DAX Copilot has done to our institution. And I will stand on a mountaintop and scream as loud as I can and say every patient and every provider deserves to use this technology. Leah, I'm finished.
That was amazing, Lance. Thank you so much. And so much to unpack there. I'm really glad to see that people are putting questions in the Q&A. Really encourage you to do that and vote on the ones that you like, so that we make sure we get time for the ones that people think are important. Just in terms of the patient case that you use, that has so many echoes for me in my own clinical practice, where we are, I am looking at patients, I'm seeing patients who are being looked after by multiple providers with multiple aspects to their presentation, where one person might have a bit of the story and then somebody else has another part of the story. And putting that all together is so important in terms of how we actually do that, and how we enable clinicians to be able to get that full picture for patients. So that really resonated for me. I've got a first question. I'm going to invite Simon and Peter-Marc. Excellent, you've come off mute and you're back on your videos. Excellent. Just listening to Lance and thinking very much, how does this apply in our setting in the NHS? So to both of you, maybe to Peter-Marc first, how do you think this type of solution can benefit us in the NHS?
So I suppose my short answer to this is not right now. And my reasoning for that, I think, won't be a surprise to many of the people on the call, is how incredibly heterogeneous our current adoption of digital is across the piece. So actually, possibly one of the areas that I'm not in a good place to talk about might be GP practice, where we are fully digitally based. And maybe there's an opportunity there, and it's not something that I'm completely familiar with. But looking in the acute sector, there's only a relatively small number of trusts that are fully digitized. There are lots that have got little pockets of digitization, obviously, but only a small number, and many of those are still on the nursery slopes of that. And I would include, my trust in that. We've been live for 15 months now with a full EPR, but the transformational exercise that we've gone through has been massive and is still ongoing. So we're still bedding it in. We are, within a few months, we were starting to realize benefits from it, but actually really polishing and moving forward. So we realize every last benefit to patient, staff, and everybody else is a journey that we can see stretching years into the future. And what's really hard to see is the point at which we could take on another big transformational piece to take that next step. I think if I just think very locally, we need to get our teams to a very widespread level of sort of digital native, so they're completely comfortable with where they are now before we take this next leap. And I completely see, how you do things like take burnout away, but it is going to be a different way of thinking and working. Without doing it, I can see that and I can feel it. And we need people to have the confidence in the systems that they're adopting to go forward and be confident that they're getting what's needed to be recorded and safe.
Thank you, Peter-Marc. Simon, do you want to come in on that?
Yeah, sure. I've been kicking around in the sort of digital health space for the last 20 years or so, I suppose, and was involved with electronic records back in the noughties. And I suppose what Lance described and what I know about DAX Copilot, I think it's a real game changer. And I think it really is going to chip away at the stress and the burnout that clinicians face. There's lots of reasons for stress and burnout, of course. But a recent survey that we did here in the NHS was clinicians are spending 13.5 hours a week just creating their notes. And out of hours, that's an extra 3.5 hours that's being done. And that's gone up by 25% over the last 7 years. And so for me, just as Lance said, it's all about giving time back for clinicians. And I really do think that this technology will be able to do that. A very recent sort of set of figures of using DAX Copilot over the last couple of months has shown that 2/3 of clinicians using it are actually spending less time on their PC. Another 2/3 are actually spending less time doing the clinical documentation, all supporting what Lance has said. I think the other interesting piece is that the quality of the content of the documentation is improved. When we're typing away, we're often cutting corners and we might miss out those pertinent negatives. And they're just as important as the positive findings. And I think those sort of findings of that sort of adoption, the patient liking it, is not bad for a new technology. Peter-Marc, I take your points. They're really key with all the pressures and the strains that are going on. One of the things that we say is that just using speech in its own right, by seeing your words come into a document, whether it be an admission note, a GP record, or whatever, getting used to the culture of using your voice by using speech is a very good first step on this journey towards DAX Copilot.
If I could just add too, I have every day I am told, I wish I would have had this years ago. I wish I would have had this years ago. There's a question in the chat about how long we have been on Epic. We've been on Epic since 2006, and we started this journey back in 2019. So, we have 13 years of experience. I get that. But what I'm finding now is that since we've launched this, we actually we gave the providers a tool which actually helps them. The EMR doesn't help you. It helps in terms of being able to collate the information, retrieve the information, that kind of thing. But for me, sitting in front of my patient, doing the work I have to do, there's a question about the benefit of it, certainly in times and in burden of having to do documentation. I have had so many providers say, I wish I would have done this. I wish we would have had this earlier. And then once you get that groundswell of, wow, they're serious, they're actually going to give us a tool that has helped me in my job, I think you'll be surprised at the amount of willingness you'll get from your providers to be more engaged in making the EMR better for themselves and for your institution and for your country, really.
Lance, can I ask you a little bit more about those enablers, and thinking particularly of Peter-Marc's point around the kind of, the upheaval that goes on with a big transformation program. Your memory of that kind of initial piece of the Epic rollout in 2006. What do you think stepped you? What were the enablers to get from that period? And I don't know how traumatic it was for you. I've heard it can be difficult in other places. Any kind of EPR rollout. What do you think got you from that to a place where you were able? I noticed on your slides that you had actually a general willingness to try something new. I mean, those are all kind of cultural mindset of people being willing to take on new technology and do the hard, and it is a hard work to be able to really get to those benefits. What do you think were those kind of key cogwheels, enablers that got you to that endpoint of being able to come to us to say, look, this is a great thing. We really did have really great impacts. What was the nitty gritty in between?
I think one of the things that we learned out of the the implementation of, because we went with Epic, and we went 100% in on day one. So we used every feature of Epic on day one. We did ambulatory first, and then 2 years later we did inpatient. But in ambulatory, we did everything. Orders, labs, everything was in Epic, and we didn't have any hodgepodge, which can be traumatic. I was in the military as a physician, and I went on and off in EMR and paper 6 different times. I'm never doing that again. So I understand that pain. I think that brings an interesting perspective to what I do. But I think a lot of institutions get caught up in this implementation, and they never get past implementation into optimization. And we tried to get to optimization of the EHR as quickly as we could, so that we could start putting pieces in place that here's your change, but now let's start using this information for our benefit. So we've been very intentional in having teams that help with optimization. And I think part of it is a little bit of culture. Ever since I've been involved in this institution, I've always said that innovation is everyone's responsibility. I can't be, as the CMIO, I can't be responsible for going into every single service line and looking at your literature, looking at your trades and saying, what does innovation mean? I need everyone's help to do that. And I think that my expectation helps with that culture. In addition, we recognize that I don't know if you've heard of the adoption curve, the Gartner adoption curve, where there are people who are going to be early adopters and late adopters, but there's also a graph on how that happens. And we are very open with our medical staff and our employees that just like each of you are on the adoption curve somewhere. Me, I'm going to get the new phone every time it comes out. I'm going to be the first in line. I for some reason I want to have it. Some people are like, nah, it's okay for me. I don't need that. But just like every individual is on an adoption curve, we as an institution are on that adoption curve, and we are a little bit on the early adopters side of the curve. And so we recognize that with our medical staff. We recognize that with our colleagues, and we just have kind of a history of doing these types of things. We were the first small hospital to be on Epic. They originally told us no, and we pushed them and said, well, we want it, we'll do it, and we pushed them into. So I think part of it is the culture, but you have to be upfront. Before we started using DAX, I did a little memo series, if you will, about adoption and innovation, the adoption curve, and I used the example of an automated teller machine, an ATM machine, and I just looked at the history of how that has progressed and used that in correlation to any new technology, and I think that stuff like that, talking about the innovation, talking about us moving forward, really helps. However, this particular tool. Our CIO says that this tool is the only tool he's ever adopted that it's been easy, and it says what it's going to do, and it actually helps. I mean, the patients love it, the providers love it. This one is easy. This to me is a no-brainer because of what it does for the system. So this wasn't as hard as it might sound.
Yeah, it's really interesting listening to you. You said, so my background is a design background, very much around user experience. And one of the things I can hear you saying, and also I think is reflected in Peter-Marc's comments, and also I can hear from what Simon is saying around the benefits, is the closeness between the intervention and actually what that outcome looks like. And I think there's something about that when it's too far away. For example, with an EPR implementation, when it's too far away from feeling like it is actually benefiting your practice and actually benefiting patient outcomes, it's really difficult to stay motivated and do that bit of hard work. It's something about that distance for me that I see over and over again. I mean, on that kind of area, Peter-Marc, you launched Epic with Dragon Medical One across Manchester. How is that project progressing? And looking back, is there something you would do differently?
So I think we were incredibly lucky in Manchester. I did have a previous role as SRO of Digital Child Health and Maternity at NHSX and then England, where what I saw was a lot of digital products being bought across organizations, being plugged in and switched on, but actually without transformational support around it. In Manchester, we've been really, really lucky. The executive team bought in. We had a huge transformational team supporting our go live. And I think the progress that we've made, interestingly, on your last comment, was actually we've brought all of our staff on board very close to seeing the benefits of deploying both systems from an early stage. If I did have one thing, I said this a few times to people, I think we needed actually to harmonize our speech recognition, transcription and everything as part of the exercise. But my personal reflection on that was trying to introduce the two technologies at exactly the same time was perhaps not ideal, because there are common pathways and ways of doing things using either our EPR or using Dragon, and there's a right balance, and actually trying to do them both at the same time, we had people diving in two different directions so that there wasn't a harmonized approach to all of it. And what it's probably left us in a position of, we haven't yet invested enough time in the opportunities that Dragon really offered us to do much more than the straight speech recognition and bringing it into patient notes on the EPR.
That's really interesting. I want to turn to some of the Q&A. So there's a question from Dave Taylor. So can DAX code symptoms, diagnoses, treatments, etc. for billing purposes and to provide structured data in the EHR needed for other AI applications?
So it doesn't currently, and I'm probably going to speak out of turn here. So Simon, maybe you have better insight than I do, but I can tell you what I've seen and what I think is happening. A number of years ago, we made a very conscious decision to move away from technologies which will read the note and come up with, the diagnosis codes and help with billing. Because quite honestly, the documentation wasn't very good. To Simon's comment, the documentation with DAX is so much better than I can ever do in the time period that I'm reasonably allotted to do it. So we wanted to implement a tool that would really help with the documentation piece of it. And now that we're there, we're looking at other tools, both within Nuance and Microsoft and outside, about natural language processing that will actually read the note, read the chart, and help us with those types of topics. So DAX itself does not do that yet. I suspect that may come in the future, but they're working on helping put the diagnoses in, do some implicit ordering, I think, at this point. But I'm sure that with that large company, there are many people working on the ability to do that, because it just makes sense. Everyone asks for it.
Well, perhaps just a short addition to that. Lance, it doesn't at the moment, but there's a whole program of work at the moment, particularly with us being part of the Microsoft family now, of what is going in the next phases of DAX Copilot. The key piece is integration into the EPRs, so that the note that you create, the correct bits of information go to the correct parts of the record, which will include them needing to be coded. We talked about the translation into different languages for patients, and then linking that to knowledge databases. There's a huge opportunity to do a lot, and our organizations are going through a process of getting that strategy in place. No specific timelines or announcements, but watch this space. And I think because Microsoft is part of us now, that the momentum from that will be really very rapid.
Does that,
I
Simon?
will say that it is a challenge. I'm sorry, Lee, if I could.
No, go for it, Lance.
That is going to be a challenge, I think, for the what we call EHRs, because I'm sure Peter-Marc could tell you that they're so focused on this structured data. Pick something from a list so that there's a smart data element attached to it, and so that data can be used somewhere else. I think there's going to be a real challenge, because now with DAX and with natural language understanding, every single piece of the chart is now could be considered structured data. You could use these tools and say, show me every time I've used the terms left toe, and it will search everything, and it will bring up left toe in a structured manner and be able to use that data for whatever reason you want it to be. So I think that we as leaders in this space have to get out of everything being structured data and start looking at tools which can turn unstructured data into the structure that we need it to be. We need to push back on the EHRs and say, we need this data to do what we needed to do, not what you needed to do.
That's a really, really interesting comment, Lance. So very much, again, one of my kind of key passion areas is around biopsychosocial models of system design. And very much for me, so I work at mental health, physical health interface and health social care interface. And the sorts of problems that the patients who come to me have, well, all patients' problems are like this. They are falling into multiple different domains, and very often we're forced into a way of recording that, which is very medicalized. The digital labelers are built around, specific, some are better than others, but that typically are supporting an acute physical hospital, very medicalized model way of doing things, which means that you miss quite important pieces of information. And that, for me, that piece where you're forcing more of that extraction in that way means that we are more likely to miss really vital information about people that allows us to actually really provide holistic care. So for me, this is really exciting, that comment around, it means all data becomes interesting, important, and accessible. That's the key piece. That's the key piece for me. It sounded to me, Simon, like some of what you were saying just now did answer Indy's question, which is in the Q&A, about linking electronic patient record for pulling patient details through, such as demographics, medication, allergies. But they also asked, can the letter be linked to the patient record? So kind of nuances of integration, I think, really, and where are we going around that?
It is very much, and it's absolutely key, and it's a really important question. So the final product of the letter can be transferred to somewhere in the EPR. To have it properly integrated, certain components of it, like if there's a problem that comes out or a procedure has been mentioned and that hasn't been documented in that appropriate part of the EPR, for that to be naturally done as part of the completion of the note taking. So that's and it's going to be working with each of the EPRs to do that over the next short while. And that, as I said, that's active work in process, and Epic is certainly one of the EPRs where that is being addressed at the moment.
So Peter Garrett's got a question that's been voted up. So interoperability is important from a UK perspective. It's just gone. Does it support SNOMED and fire messaging standards? And I think I would also add to that, again, a little plea around interoperability, not just in terms of the kind of technical standards, etc., but also about supporting different models of care. I don't know if I'd be interested in everyone's comments around that, about how these sorts of technologies are going to approach that. Simon, do you want to go first?
Well, the latest version of DAX Copilot went for general release in the US just last month. And as part of that process, Lance mentioned that term private preview. And what that means is that a large number of clinicians, in this case, I think it was something like 300 clinicians in 50 healthcare organizations, road test the latest versions. We in the UK, we are in the process of creating a strategy to do a similar piece of work, because DAX Copilot coming to the UK, we want to make sure that it's going to meet the needs of both technically and clinically of the workflows in an NHS environment. So those sort of questions are going to be part of that overall process going forward. Lance, I'm not sure whether you've got any feedback from how far where you've got to there in the US side of things.
Yeah, I'm not sure, the complete structure of how you all interoperate over in the UK, but all the interoperability for us is right within the EMR, and so currently DAX does not give diagnosis codes, so we enter those, and so those are SNOMED enabled, and all the interoperability occurs between Epic and Epic, or Epic and our health exchanges here in the US. So that has not been a question about the FHIR messaging standards. That all happens within Epic, and they take care of that. DAX currently is allowing us to generate that note and put that into the EHR, or you guys, is it ERP? Is that what you guys call it? ERP, electronic patient, right? EPR.
Patient record, yes.
Yeah, okay, the terminology here. So yeah, so the EPR, I think would handle that. Out of Peter-Marc, if you have the final answer on that.
So I feel I'm being the voice of just the practical existence of being in the NHS here, actually, and I am reflecting a little bit back at my time when I was at NHSX again. I think the massive frustration, having worked both nationally and at a more local level, is, the NHS exists as a series of federated organisations, and actually there isn't an oversight that enforces that things are done in a particular way. There can be all sorts of carrots and sticks put in place, but the maternity team have generated a full set of maternity standards with a definition of what should be included in a maternity EPR in a very non-system specific way. So it's a proper specification, but it isn't enforced. So a trust can go out and can use it as a tool to try and select the best of the EPRs available to solve their maternity problems. But actually, if they at the end of the day say, well, do you know what? The implementation of that one will actually cost us 4 million less this year than the other one. I'm afraid we're just going to have to cut our losses, and we're not going to deliver to that standard. And I find that incredibly frustrating. I really, really would love a steer from the top that says, these are the basic standards. These are the must-dos if you use a Moscow scale around the specs for various things that we're doing. And you must buy systems, otherwise you can't procure it. You're just not allowed to buy a system that doesn't meet these standards.
That's really interesting. I was just there's a couple of questions that were around just around that implementation point you were making earlier, Peter-Marc. So I think Kenneth Harden's asked around how long it takes to train on Copilot. Have you got?
So obviously I've not used Copilot. I've used Dragon itself, and Dragon takes to your voice, I mean, better than any other voice recognition thing I've ever used, to be honest, including all the ones that we all know out there, Alexa, Siri, whatever else. It works extremely well with medical language. And one of the first demos, when we were actually demonstrated it, one of my colleagues, pre our go live and everything, with an incredibly broad accent, and we all sort of smiled when he stepped up to use it, and it transcribed what he said absolutely beautifully before any voice training at all. And obviously you're able to refine that and take it forward, and I would say it's a very intuitive, very straightforward system to use, to be honest. Some of the real tricks that improve your workflow are by allowing it to trigger either drop-in of sort of whole sentences, or indeed trigger the EPR to do various actions. Takes a little bit more work, and perhaps at this point in time, the way it's all configured needs that really enthusiastic person who's going to sit down and do it, rather than it being instantly available to everybody. But I think that's just part of the journey that everything's on. And
that instantly makes me think about how poor we are at doing things like interaction mapping. So to actually understand that underpinning service design, that's where the hard work really comes into.
Yeah, very definitely.
Yeah, absolutely. So we're coming up almost to the end, and I wanted to offer the last words to Lance, really, around just where you think what are the biggest issues you think we need to be thinking about when we're thinking the NHS about what is going to help us tackle these really big issues you're talking about in terms of physician burnout, improving care. What are your sort of final comments for us, Lance, as we come to the end of the webinar?
Well, specifically to physician burnout, I'm no expert in this, but I think one, it needs to be recognized for one, and need to be recognized for what it is. I know there's a lot of I don't know if controversy is the right word, but there is a lot of talk about, everyone's working hard. Everyone's job can be a bit stressful. But physician burnout is like I said, during the pandemic, 70% of providers feeling burnout, 2/3 are thinking of leaving the profession. Where would that leave our industry if that actually happened? I think that just needs to be recognized for what it is, and the fact that there is an impact. It's kind of like global warming. You can or change in weather. You can argue about who caused it, whether it's the weather's changing. Okay, it's just like physician burnout is there. So what are we going to do about it? And it's a multi-pronged approach. We've done several things over the last several years. We even created an Office of Professional Wellbeing, which is tasked to doing things with our providers and for our providers to help decrease burnout. Everything from, let's just have a party to, let's provide, elbow to elbow support, one-on-one support for a number of things, including the EMR. There's emotional support, that can be offered through the OPWB. So I think recognizing it there. But I think looking at the causes of burnout and really what technologies that are out there and are available to really address those issues, which do other things that we wanted to do, allow us to provide better patient care, higher quality, more efficiently, and really aid us. And we have a Dr. Cooper, who is the CMIO at, I'm sorry, he's Dr. Maz. He's a CMIO at Cooper. He always says, we've put a lot of data into this EHR. Let's figure out how we can get data out of it. And so I really think that some of these tools can help providers, take better care of their patients with less of an administrative burden and with a little more of that autonomy. So I really think that's what it boils down to as far as using these tools to address physician burnout. But it's not just that. I mean, I have statistics that, other things in our system. For example, we have an issue with prior authorizations here, where we order a certain test and we have to, get approval from the insurance companies to get it ordered. We've noticed a 40% improvement in first-time approval of prior authorizations because the documentation is just so good. It's captured, and the insurance companies want to know why you want that MRI. Here's the patient record, and they're like, oh, okay. The camaraderie that can occur when the stress is just down inside the office because there's the providers are less burdened. They're less stressed. Their notes are done. That you're able to do other things within the day. It just greases the wheels of medical practice, and I think this is a really important concept of other than looking just at these ROIs, of looking at what it does for the practice of medicine.
Thank you so much, Lance. Peter-Marc, did you want to?
Yeah, I did. I'm really, having said I'm the practical man, I'm really excited by all this, but I think there's another angle that we perhaps haven't talked about and haven't got time for now. But, we're sitting here, and forgive me, Lance, for saying this, but, we're quite silver-haired, very established clinicians. I wonder what taking this part away and that sitting down, writing out your notes or typing out your notes, how that alters the cognitive process, particularly for younger clinicians coming through the system. That's something we're going to have to understand over the next few years, because I don't know whether that's going to be a positive or negative effect.
We're having a discussion right now about whether or not we should give this to our residents, because I agree with you. I think there is a real benefit to understanding the cognition of writing the note. And then if you give it to residents, for example, and they leave your institution, now they've had the use of this tool for 1, 2, 3 years, and they go somewhere which maybe doesn't have it. That might be a detriment to us as well. So there is a push here in the States to give it to the residents and the house staff. But we'll see how it goes. But I agree. Maybe we should talk offline on that.
That's that is totally my bag, that area, and that is definitely something I would love for us to talk about again. And I think it is definitely something about how we are really affecting these models of care with these types of digital enablers. And I think it's a really important topic to come back to. So it just remains for me to thank everybody. Thank you so much all for your participation. Thank you everyone, webinar participants, for the questions that you put in the chat. I'm sorry we couldn't get to all of them. We should be able to make Lance's slides available to people who are signed up. That will come later. And just thank you all very much for joining us, and I hope you have a lovely rest of your day. Thank you very much.
Thanks for the opportunity.